Good afternoon, everyone, and welcome to this public listening session on caring for patients with chronic pain, perspectives from clinicians. Today's webinar is organized by NAM's Action Collaborative on Countering the U.S. Opioid Epidemic. My name is Helen Burston. I am the EVP and CEO of the Council of Medical Specialty Societies. Together with Deb Horry from the CDC, I co-lead the Pain Management Guidelines and Evidence Standards Working Group for the Action Collaborative. The listening session today will last about 120 minutes and will follow the following structure. We'll begin by having an overview of the Action Collaborative and its work. We'll talk briefly about the Action Collaborative's working groups, focusing specifically on our Pain Management Guidelines and Evidence Standards Working Group, including how the listening session today will inform the work of this group. After the opening remarks, we'll introduce the panel and move into the main part of today's program, which is a guided discussion with a panel of diverse clinicians covering 5 questions around pain management. These questions are also open to our clinical audience for written response. After our last question, we'll close out the session and share opportunities to engage with the Action Collaborative. We hope you join the conversation on social media and tweet over the course of the webinar by using the hashtag #OpioidCollaborative. I'd also like to acknowledge and thank the sponsors of the Action Collaborative who make this work possible, and you can see the lists and the logos on this slide. And with that, let's go ahead and kick off the program by providing a brief overview of the Action Collaborative. The Action Collaborative is really a remarkable public-private partnership of over 60 members from the public, private, and nonprofit sectors. The mission of the Action Collaborative is to convene these diverse groups to catalyze the development, curation, and dissemination of multi-sector solutions to ultimately reduce opioid misuse and, really importantly, improve outcomes for individuals, families, and communities affected by the opioid crisis. In order to enact this mission, our Action Collaborative has 3 foundational goals for all of its work. First, to identify and raise the visibility of complex challenges, including outstanding research gaps and the needs of the opioid crisis that require a collective multi-sectoral response. The second is to elevate and accelerate evidence-based, multi-sectoral, and interprofessional solutions to improve outcomes for those affected by the opioid crisis. And last, the Action Collaborative aims to catalyze action on these shared priorities and solutions to help overcome the crisis and improve outcomes for all. Next, I want to give you an overview of the 4 priority areas of the Action Collaborative, which are health professional education and training, pain management and evidence standards, prevention, treatment, and recovery, and research, data, and metrics needs. The Action Collaborative is structured so that it's organized into these working groups. As co-lead of the Action Collaborative's Pain Management Working Group, I want to introduce the work of our working group and share the objective of today's listening session, as well as what it will help inform. So the working group has organized this listening session, and really a series of mini sessions to collect input on the state of chronic pain management and to understand the intended and unintended consequences of changes to opioid prescribing guidelines and related metrics as they pertain to the delivery, access, and coordination of pain management services. The first listening session in this series was last month, where we focus on the experiences and perspectives of persons living with chronic non-cancer pain. Key themes from the discussion of that session included communication in clinical settings, perceptions of compassion, clinical attitudes and biases, as well as disparities and issues of access as they pertain to chronic pain management and care. We will revisit these themes in the discussion today with our panel of clinicians. In addition, this session will help inform the creation of a person-centered chronic pain journey map. This will really help us illuminate what are the practice and system-level gaps in chronic pain management, opportunities to strengthen pain clinician communication, and accelerate the uptake of a range of pain treatments to improve outcomes for all. All right. Let's move into the main discussion. We're excited about this part of the discussion because we get to hear from others in the field who have really been able to provide on-the-ground experience for where they have been and their perception of this issue. So we're going to walk through this program, and I will help moderate it for the next hour and 40 minutes or so. Please note the webinar is being recorded and will be available for access on the Action Collaborative's website. Today's listening session features a panel of 5 clinicians who will span the spectrum of healthcare services. The discussion today will focus on their experiences and perspectives caring for patients with chronic non-cancer pain. Due to time constraints, unfortunately, we will not be able to take live questions from the audience. However, there will be an opportunity for the audience to participate in the session by submitting their written responses to the discussion questions covered with today's panel. And I will tell you from our first listening session with patients, it was remarkable to see the robust response from the community. So we really do invite you to submit your perspectives on this today. So first and foremost, let's start, and I'll let the panelists introduce themselves, starting with Dr. Gary Leroy.
Thank you very much. This is Dr. Gary Leroy from Dayton, Ohio, president of the American Academy of Family Physicians.
Great. Thank you so much, Dr. Leroy. Trip Logan.
Hello, everybody. My name's Trip Logan. I'm a second-generation community pharmacist and community pharmacy owner from Southeast Missouri. Thank you.
Great. Thank you so much, Trip. Charles Resnikoff.
Hi, my name is Charlie Resnikoff. I'm an internal medicine and addiction medicine doctor at Hennepin Healthcare and at the University of Minnesota. And I also am involved in some opioid regulations with the state of Minnesota.
Great. Thank you so much, Charlie. Mark Sullivan.
Hi, this is Mark Sullivan. I'm a professor at the University of Washington in Seattle. I've been doing clinical work in chronic pain care for 30 years and researching opioid therapy for chronic pain for about the past 15 years.
Perfect, thank you. And Matt Tierney. Matt, are you with us? Are you on mute?
Oh, I was on mute. Sorry about that.
It's the story of our lives. We've all done it. Yes, we can. Go ahead, Matt.
Sorry about that. I'm Matt Tierney. I'm an advanced practice nurse and nurse practitioner from University of California, San Francisco. My specialty certifications include adult primary care, psychiatric mental health, and certified addictions nursing.
Perfect. Thanks so much, Matt. Okay, so thanks for all being part of today's panel. We're looking forward to a great conversation with all of you. Let's start the discussion with question 1. What successes or challenges have you had in providing care to patients with chronic pain? Let's begin with you, Charlie.
Oh, okay. Well, again, before I begin, I just want to thank you for having me and thank everyone for listening. This is a great opportunity. Successes and challenges. We have a true multidisciplinary pain clinic, and it is incredible to see. We have an embedded integrative health doctor. We have an embedded pain psychologist. I'm an addiction doc embedded in the pain clinic. We have a very active PharmD who helps us. The nurses are incredible, and they're all up to speed on the protocol. So we have this really amazing team. And I think one of our successes is building that team. And I think another success is that care team meets once a week to debrief on patients that worry us, on issues that came up, and to try to problem solve, set up referrals, and things like that for our patients. So we have a really good team, and we work well together as a team, including that once-a-week debriefing on concerning issues. I would say challenges. I work at a county hospital, and we have this amazing, highly diverse population. I mean, we have refugees, we have Native American people, we have businessmen from downtown, we have all this incredible diverse population. However, I am a white male, so I have to communicate with all these folks. And then every time a new regulation happens, that ups the ante for me to be able to communicate effectively with my patients. And it is often mistaken, am I am I the one who created all these regulations, or am I just the messenger? And do my patients truly trust that I am advocating for them when a lot of my time is spent enforcing rules that are put on me? And so it's very frustrating. And I brought up the racial dynamics and the ethnic and socioeconomic dynamics only as an example. Even that aside, the communication is challenging. So I think that would be our challenge.
Great. I suspect we're going to hear a lot of those themes today. Let me turn to you next, Gary.
Thanks a lot. So treating chronic pain is a challenge in any setting, and it involves understanding the nature of the illness, the origin of the pain, and how the pain impacts the patient's activities of daily living. Each patient is unique in his or her ability to understand and cope with the varying degrees of pain, and I find a detailed explanation of the etiology of their pain, if they know that, and the treatment options is critically important. And we need to begin very low with our treatment modalities and go slow after the acute phase of pain treatment, which is usually within about 24 to 72 hours when that's passed. If the patient's on opiate pain reliever when they present to their care to me, we discuss how to go about weaning them off of the agent. And, one of the challenges is discussing the alternative treatment options and the office protocols for chronic pain treatment. And we have them sign a narcotic contract, and we need to have these frequent office visits that are follow-ups for surveillance or a referral to pain management specialists. And we also discuss other things that are of concern to the patient. So again, the challenge is really knowing their history of pain medication use and/or their dependence on these medications. And it's clearly stated that drug-seeking behavior is not to be tolerated. And success in where I live in Montgomery County, Dayton is the county seat of Montgomery County, was the establishment of a community unintended drug overdose task force way back in 2010, which was several years before the drug opioid crisis had been noted in the media. And this was to address the rising number of deaths in Montgomery County. We had about 120 of these deaths each year from opioids. And so that was a success because we were able to increase awareness about this disorder long before it became a national crisis.
Great. Thank you so much. Mark?
Hello, this is Mark Sullivan, and I have been doing chronic pain care for over 30 years. So I've seen different waves or eras in chronic pain care. When I was first trained here at the University of Washington, I was in the world's first pain rehabilitation program that John Bonica had started here. And I was very oriented towards functional improvement away from symptom relief and opioid therapy. Through the 90s and into the 2000s, we transitioned into a period where we were measuring pain with 0 to 10 scales and feeling like we had the duty to drive down those scores. Since then, things have been shifting away from opioids as not so safe and effective, and we're, I think, still kind of grappling for what I call the post-opioid era of pain care is going to be like. Sure. Throughout that period, I have felt both the great satisfaction and the considerable frustrations of caring for people with chronic pain. I have to say that I'm probably one of 2 or 3, quote, pain psychiatrists in my state. So there are not a lot of services for the common mental health comorbidities in patients with chronic pain. But it is certainly a satisfying line of work when you can get people their lives back. It can also be frustrating when it feels like we're talking past each other about the appropriateness of different treatments and the goals of care. I'm happy that I'm having some success at training pain fellows, psychiatric residents, anesthesia residents to learn how satisfying and fun, really, chronic pain care can be. So it's been a very rich, although mixed fixture throughout my career. Thanks.
Great. Thanks so much, Mark. Matt? Are you on mute, Matt? Let's jump ahead.
You can hear me now?
Oh, yes. Go ahead, Matt.
Great. Sorry, I'm on two systems here, both a computer and a phone. So this is Matt Tierney. Thanks so much, Helen. I want to start by sort of giving a preamble that my responses to the successes and challenges are informed not only by my specialties in adult primary care, in mental health and in addictions nursing, but also by the two treatment settings where I've spent most of the last 12.5 years practicing. The first was a buprenorphine induction clinic that I would operate for the city and county of San Francisco. That was very much a model for the current hub and spoke models for medication-assisted treatment. And in that setting, half or more of our clients experience not only the problem of opioid use disorder, but also chronic pain. And the second treatment setting is at a prescription opioid safety team as part of the San Francisco Veterans Administration Healthcare. And that team was created in response to a Veterans Administration mandate to address the opioid overdose epidemic among veterans who had higher rates than the general population of opioid-related overdoses and deaths, as well as high co-occurring rates of mental health and substance use disorders. So with all of that experience, my answer is really informed by the knowledge that chronic pain does not exist in a vacuum, and neither do the people with a lived experience of chronic pain or the systems and providers that strive to effectively address chronic pain. And I have been thankful to enjoy some success in broadly assessing and addressing patient pain, inclusive of patients' individual experiences, and inclusive of patients' experiences of varied mental status and addiction risks. And I've also had some success in initiating a spectrum of treatments as needed, including better pain management, better mental health care and supports, and treatment for opioid use disorder when present. I've really enjoyed that the successful diagnosis and treatment of mental health problems and opioid use disorder often results in better pain management. I think another success for me is enjoying the engagement and conversations with patients about the risks of opioid therapies, which patients are really well informed about now and eager to discuss. And then for me, some of the challenges include that both patients and providers have become attached to ineffective or suboptimal treatment regimens, high levels of patient and provider frustration, and that patients often feel intervention fatigue, especially when every new provider or specialist feels obliged to start at the starting blocks with a long medical history, and that treatment changes are often postponed until subsequent visits.
Great. Thanks so much, Matt. Trip?
Yeah, my story is a little bit different, and from a community pharmacy perspective, I'd say I graduated pharmacy school in 2002, which means when I was in school, we had the smiling face to the frowny face pain scale, and we were taught that was something that we needed to address. And when I got into practice in the early 2000s, that was right in the middle of opioid prescriptions and overuse and pill mills, and I was dropped right in the middle of that, and it was really eye-opening. And like many other things in healthcare, what we see, and really just in life in general, but particularly around regulation and payment, it's like a rubber band. And so we had that really loose system at that point, and then what we've seen since then is the rubber band going the other way with some overcompensation, what we believe to oftentimes hurt the patients that we're dealing with. And when we're talking about the successes and challenges, the biggest success on our side is we've definitely engaged in a closer collaboration with local prescribers, not only to reduce the morphine milligram equivalents, help them calculate, become a resource for our local prescribers, but also in care planning and coming up with opioid reduction strategies, tablet reduction strategies. And in the past, going back to when I first got out of school, sometimes often there was some little friction between the pharmacy and the prescriber's office over opioid prescriptions. Now we're seeing a whole lot more collaboration, and we've used that as an opportunity just to work more closely with the docs and the nurse practitioners that we work closely with, just at a deeper level with care planning. The bad news is when we're working with a lot of these guys, it starts being real clear that we can have the best physician, pharmacist, patient, all in, everybody's bought in. We've got a care plan in place, a reduction strategy. We've got an 18-month plan to get this 10-year non-cancer chronic pain patient transitioned off of their current regimen into something that's probably a little more beneficial for them. And we run into coverage issues, new formulary changes, coverage edits. Out-of-pocket costs get to be a barrier. We spend a lot of time working. Our local prescribers are really sensitive to tablet count, and so we help them develop strategies to lower MMEs over time with maybe a long-acting, low-dose opioid and some immediate release for breakthrough pain, and reduce slowly over time and to gradually decrease. But what we run into is a lot of third-party coverage edits around that. Long-acting opioids not covered. Payer is telling us that our engagement strategy with the patient, which maybe we're all bought into, that we've got a game plan, we're ready to go, but the payer requires a more rapid reduction in MMEs than we really feel appropriate collectively for the patient. So then you work through all that. Let's talk about the administrative burden on the prescriber's office, the administrative burden on the pharmacy, and then the emotional burden on the patient that we've worked through this strategy, and then we point, and pharmacy says it's not covered. It's just a really tough situation at a super crucial time. And so we've experienced a lot of that. We've had successes with the strategy, but those aren't the ones that really resonate as much as the patients that we run into that roadblock there at the end. And it's just unfortunately fairly common with the patients that we see.
No, that makes perfect sense. And it's very interesting listening to all of you, how many similarities there are in terms of the clear successes being around teamwork, advocating for patients, understanding their lived experience, but also all the roadblocks around coverage, regulations, and other issues. So lots to discuss here. Let's go to the next question if we could. How have prescribing guidelines for either prescribing or dispensing of meds and opioids for chronic pain positively impacted the people in your care? And how have they negatively impacted the people in your care? This time around, let's begin with Gary.
All right, great, thanks. So as I mentioned previously, I have the privilege of being a co-chair of the Prescription Drug Overdose Task Force that predated many of the prescribing guidelines that have now been imposed by the federal government and the state governments and such. In this task force, when you were talking about teamwork, this is a task force of, there must have been about 30 different entities there, from the criminal justice system, the police, the coroner, pharmacists, nursing, government, and first responders. It increased, the positive was that it increased the awareness of the true nature of the cause of the deaths in our county. I mentioned that there were, on average, 120 of these deaths in our county that were witnessed by first responders. And And again, these were, we found that the real cause, they thought, well, it's because we have too much heroin on the street. And when we put all the facts together, we actually found that opioids taken in combination with other sedatives or other drugs like alcohol and marijuana and such is what was causing these numbers of deaths in our county. And so from that, we got the recommendation about having our first responders begin the use of Narcan, and prescribers of opioid medications began to actually use less opioids for pain management. So that was a positive of that. But the negative impact was that these patients actually began, ironically enough, to turn to heroin and other diverted prescription drugs as a substitute for pain relief because they weren't getting these from the usual prescribers in the community. I don't know if some of our listeners have read the book by Sam Quinlan. It's called Dreamland, which outlines how and why this happened in the Ohio River Valley, the Ohio Valley as well as northern Kentucky region. And actually what happened, and what about 2 years after we began that task force in about 2012, that's resulted in an actual increase in the number of deaths in our county, reaching a peak in 2017 of 556 deaths in Montgomery County. And that was a negative effect. And actually, we saw that in 2012, that increase. And then nationally, we saw that after the narcotic crisis started, or was dubbed that in 2015, about 2017 is where it peaked out at. So that was really a negative effect, and we saw that before it was seen nationally.
Great. Thanks so much, Gary. Tripp, I'm sure you have lots to say about this one.
Be careful giving me a microphone. When I was looking at this question, I was like, man, this is a tough one because there's so many things. I think back to the old days in my early practice when I don't know that I could have told you what a morphine milligram equivalent was. It wasn't something we were actively counting. It wasn't something that we thought we needed to be paying close attention to. And so the new guidelines have really made us look at patients that are on opioids a little bit different, which is definitely a positive. Sitting in southeast Missouri right now, the only state in the union without a prescription drug monitoring program statewide, I can also say that these guidelines have put more pressure on our state to get an active PDMP in place, and I think that this year's the year, so that's exciting as well. And then, again, I go back to the collaboration between local prescribers, the providers, primary care and otherwise, and the pharmacists. It's really improved, which is good. And I would say the CDC guidelines have really contributed to that. But, just like anything else, when you're not measuring, then you don't pay as close of attention. And once you start measuring something, you're going to really try to move the needle. What we found in practice was that the guidelines, through a lot of formularies and a lot of payer initiatives, have really turned into more of mandates than guidelines. There's very little flexibility. They're really population health driven, very cookie cutter type. Opioid reduction strategy is the main goal, not really allowing for personalized, patient-centric, slow, strategic opioid reduction care planning. And for the patient-centric physician pharmacist team, it's been really troubling, really, really troubling. So that's a byproduct of guidelines being implemented very rigidly when I think minimizing risk for a payer is not having it on my books, meaning we don't pay for it, we don't have an adjudicated claim, I'm good. What that doesn't always mean is that the end patient didn't get that opioid. And so somehow marrying these things together is what I feel like needs to happen. And we've done, back to the rubber band analogy, I feel like we've gone from way too loose to way too rigid, and ultimately our patients are the ones that are suffering.
Yeah, no, that makes sense. Matt, please.
Thanks, Helen. To me, the positive impact of guidelines is that patients really seem to appreciate an opportunity for clearly discussing a range of factors included in the guidelines, such as the health risks associated with chronic opioid therapy. So I like that framework of the guidelines that allows us to reference with patients a number of related factors. For instance, treatment duration. Patients will ask, and we need to engage in conversation with them. What is the expected length of treatment for chronic pain? How long can I expect to be on an agent? When can I expect to taper off, or should I taper off? Another example is the risks of combining opioids with benzodiazepines, and then applying that to patient-specific situations. So, for instance, having a framework then to be able to discuss with a patient why opioids and benzos in general can be a risky combination, but then for them specifically, what does it mean for their obstructive sleep apnea or their COPD or their risk for falls because of their peripheral neuropathy? And it allows us to really engage with patients on a very detailed level, and allows us to be patient-centered rather than provider-centered. I also think a positive impact of the guidelines is an opportunity to assess and diagnose, as I mentioned before, related and highly prevalent co-occurring problems, such as depression or substance use disorder. So when we're thinking about depression, really engaging in a conversation with a patient, is the depression caused by pain, or did it precede pain? Is depression worsened by pain? And then questions of substance use, which really gives us an opportunity to talk to patients about a substance use disorder is really about a use of a substance that has somehow gotten out of control. And to take that sort of blaming and shaming language out of it, and then to be able to detail, is that substance use disorder mild, moderate, or severe based on the patient's current situation. And then if I think about the negative impact of guidelines, I think primarily about how we reasonably need to respond to patients' questions when they ask, why weren't guidelines in place like this when I was initiated on chronic opioid therapy? It really helps us put a self-reflective lens on ourselves as providers. Do we really know the answers? What is the evidence behind the answers? And are there some times when we make recommendations because it's the best recommendation we have without a great deal of evidence? And I think that can, if we engage appropriately and with a true self-reflective and patient-centered approach to that, those can be really rich conversations and rich opportunities for professional growth as well.
Absolutely. I'll turn to you, Mark.
Hi, I would like to reflect a bit on the history of treatment guidelines, specifically opioid dosing guidelines. I was part of a panel here in Washington State that developed the first opioid treatment guidelines that included dosing guidance, namely a recommendation that primary care obtain a pain specialty consultation if they were using over 120 milligrams of morphine or equivalent per day. And that was prompted by our state medical director of workers' comp program, who noticed that a lot of his injured workers that were on high-dose opioids were dying. So that was controversial. We got a lot of pushback from not just pharmaceutical companies, but pain professional organizations who felt we were denying people appropriate care. Subsequently, it was a model for the current CDC guidelines, but it's important to know that these guidelines with dosing guidance have always been popular with our primary care community here in Washington because they felt compelled to dose escalate in search of pain relief with patients and weren't really comfortable with that. So they referred to our dosing threshold as a line in the sand where they felt it was, a good time to start thinking about something other than continued dose escalations. We're, of course, and I think that's a very positive effect of the dosing guidelines. I think that there's really not a good evidence base for particularly high-dose long-term opioid therapy, as the 2015 NIH conference documented. So I think they have been a positive force, but I want to also comment on the negative force, which has to do with what we're now calling legacy patients who've been on long-term opioid therapy for a long time. And many health systems, payers, regulatory bodies have gotten a little bit more black and white and heavy-handed about dosing guidelines than the CDC intended, so that patients who were doing relatively well were being forced down to get below the CDC thresholds. And the CDC themselves wrote a New England Journal article making clear that that was not the intention, to taper people who are not showing risks. So I think, as always, the kind of subtlety and the nuance in the guidelines, people rarely read the long version of the CDC guidelines, they just read the bullet points. But if you do read the long version, you'll notice there's a fair bit of nuance and discretion allowed in there. And I think it's other systems that have, gotten a little more heavy-handed and black and white in their implementation of these guidelines that have caused some suffering. In fact, there's a brand new paper out in the British Medical Journal that some colleagues just sent me, a very large VA data set showing that people who are discontinued from opioids are increased risk for overdose and death subsequently. Interestingly, the risk is related to the length of time that they've been on the opioids. So the longer that you're on opioids, the more risk you're at for bad outcomes after discontinuation. So it's a complicated situation.
Yeah, it certainly sounds like it. And Charlie?
Okay. So, I think a lot of really good comments have already been said. So, how has it positively impacted patients? Well, it's improved consistency. It's raised the standard of care. It's made almost, a given certain conversations, certain interventions, certain referrals available that weren't available before. When something's in a guideline, it goes from really kind of optional, do I happen to think about it, to codified and baked into the clinical practice. So, a lot of good things have gotten baked into the practice of pain medicine. Getting your drug screens, having routine, the awareness of the dose of opioids, routine conversations about opioids with patients, availability, the knowledge of the importance of availability of referrals for addiction and mental health, et cetera. All those things are excellent. I want to call out one other point we haven't mentioned yet that's a positive of the guidelines. It has forced a sort of quality improvement understanding of our pain clinics. In other words, our pain clinic has the complete data of all of our patients. And you can't do quality improvement without the data. And that's a good thing. We actually know who we're treating. We know what our doses are. We can look at a provider and determine that provider's number of patients, average MME, all that stuff with a click of a button. These are positives that we can use to understand our practice better. So true quality improvement is enabled by understanding our data, and I think we understand our data because we were forced to by these guidelines. So I think those are all good. The negatives we heard already, loss of individualized care, loss of personalized care, and more importantly than the loss of personalized care, the patient's feeling that they're being put into a cookie-cutter situation. And so estrangement with the patients, frustration on the part of the patients. Those are all the byproduct of applying these guidelines. And as someone mentioned earlier, the guidelines are being misapplied. And we don't know which components of those guidelines are actually helpful and which components of those guidelines are well-meaning but won't shake out to be helpful in the end. So we have these kind of imperfect guidelines that are being misapplied that patients are frustrated with. And I've been involved in developing some guidelines, and then, a month later, someone applies a guideline that I helped develop to me, and it's clear that that person doesn't even understand what was behind this and what was the evidence and what was the intent. So there is a lot of misapplication of these guidelines, and that's worrisome. And so, there's some good things and some bad things, but I hopefully when we can raise the standard of care, improve our consistency, understand our quality improvement data, while still allowing for individualized care, personalized care, and while still connecting with our patients. That's the hope, but it's challenging right now.
Yeah, very much the discussions that we've been having in our work group as well about real concerns about the double-edged sword that the guidelines have put out into practice, while certainly helping to standardize care and perhaps improve collaboration and improve data. There are some real downsides around loss of personalized care, increased use of illicit drugs, as you all pointed out. And I think also really this important concept, I think, of the fact that the nuance is often missed so that they can be both misapplied as well as misunderstood. Really important comments. Thank you so much. Let's go on to the next question. So for this question, how have these guidelines for prescribing and dispensing medications and opioids for chronic pain positively impacted your practice, and how have they negatively influenced your daily clinical practice? And I recognize some of that may kind of bleed over from the last discussion, but we'd still love your thoughts about the overall concept of how it influences practice. This time around, let's begin with Mark.
I think that the guidelines have shifted the emphasis in chronic pain care from opioid care. We were consulted almost solely by patients already on opioids in recent years, and we are now getting patients either on no opioids or low-dose opioids, where they are looking for other ideas. Some patients really think opioids are still the key to relief from their chronic pain, but there is a shift away. I think we've already discussed the negative influence in that public health, population health-driven policies about safety, patients and sometimes providers can think that doesn't apply to me, because they're not experiencing it over a number of years of personal use. So they can feel oppressed or manipulated by guidelines that are derived from population-based data. So I think in general, the guidelines have been improving care, that patients are doing better, there's less serious opioid adverse events, but we're certainly in a period of transition where there's been, a fair number of people, and I'm talking millions of patients on long-term opioid therapy, and they were to some extent sold a bill of goods by us when we thought that therapy was safe and effective on a population basis. And now that we don't think that anymore, they think they're feeling a little ripped off by the whole process. So I think that there's some legitimacy to those feelings. Not that the science is not good, but we've got some casualties of a bit of a whipsaw in policy and science.
Yeah, I agree. I think many of us clinicians felt pretty like we were sold a bill of goods too, certainly. Let's go to Matt next.
Hi. So your preamble, Helen, is very much appropriate because I am going to refer to some comments I had made earlier. I think the positive impact on my practice is that the guidelines have really opened a door to practice which exists at the intersecting set of chronic pain, mental health, and risk for substance use disorders. And I think we have a better understanding of each of those informed by the other. And I think the guidelines have assisted with that. I think the negative impact, I'm going to reflect on comments that Dr. Sullivan and Dr. Resnick have already made. Negative impact is there's a real provider misunderstanding of the guidelines. For example, a lot of providers believe that the CDC guidelines for chronic opioid therapy recommend tapering when patients have been on long-term therapy, and they absolutely don't. And I think of an example of a patient who was referred to me for buprenorphine induction, who had some aberrant behavior, namely she needed numerous early refills or was taking more of her chronic pain medication than was detailed in her prescription. And after a couple of early refills, her community provider simply cut her off because she believed that guidelines recommended a quick stop in the context of aberrant behaviors. And what happened for this client, so the patient was discontinued from her opioid analgesic and referred to buprenorphine clinic where I met her. But this was also a busy mom. She was a single mom with 4 kids. She was discontinued from her opiate in November. She had prioritized holiday arrangements for her family, for Thanksgiving, for Christmas, and she had prioritized end of semester school support for her school-age kids. So she could not make it into buprenorphine induction clinic, and she went to the street to get opioids illicitly, which just opens the door to such a huge range of risks, not just from getting a drug that might not be an opioid at all, or might be fentanyl or carfentanil, but also the potential for violence and experiencing harms going out on the street to get drugs, et cetera. And this was a patient who was very experienced with recovery. She had been abstinent from stimulant abuse for many years. So by the time she got to buprenorphine clinic, we successfully induced her on treatment. And because she was such a savvy patient and person in recovery, she was able to repair the relationship with her community provider, who had very quickly discontinued her opiate. But not all situations turn out that well. And so, you know, again, just to summarize, the negative impact is really kind of a misunderstanding of the guidelines, and that these are hard and fast rules, that it's created a black and white environment when really there's a lot of wiggle room, and the guidelines are simply guidelines.
Absolutely, and thanks for putting a personal patient face on that story. It's really important. Charlie, we'll go to you next.
Okay, yeah, and for good or for bad, I interpreted this question a little selfishly, positive impact on my practice and negative influence my daily clinical work. So I'm going to be selfish and say, how did it positively affect me as a provider? So I'm in a unique spot, and then I'm an addiction consultant to a pain clinic. And I have had such an amazing, enriching opportunity to do consultations on pain patients, and they really afford me, 45 minutes per patient to just sit and talk to them and understand them and to listen. And that has been so rewarding personally, to meet these patients and hear them and hear their stories, and has really taught me a lot. And then also, for those who meet criteria for opioid use disorder, to get to transfer them onto another medication such as buprenorphine and watch them do well has been really rewarding. So that's been really an amazing experience for me, to be at the threshold of change, so to speak. The negative is that as an addiction provider in the pain world, I see, and I suffer from a little incredible, excuse me for saying this, incredible ignorance about what addiction is. And I sometimes I want to say, dude, Google opioid use disorder criteria. Just Google it. I want to say that to the people getting a consult with me, because some of the consults are, this person looks funny, or something's wrong and I can't tell what, or any quote-unquote aberrant behavior can be confused with addiction. But there's an actual list of criteria, And so, anytime anything funny happens in the clinic, they sort of bring me into, half the time I'm a mediator and not even a proper consultant. And I don't know, maybe that's just the life of a consultant, is that you're always complaining about the quality of the consults. But I do think that, general understanding about what opioid use disorder is, how to make the diagnosis, and how to sort of do some work on the consultation before you ask for it, would help pain care to be better. And then finally, the so-called warm handoff. If you haven't heard this term, it's kind of a funny term, the warm handoff. I think patients get referred to me without fully being told what they're in for. And then they show up and they're surprised that they're sitting in the room with an addiction doctor. And that causes I have to back up and do a lot of work just to get them to de-escalate and calm down and engage with me. And that's gotten better lately, but the no-show rate has been too high, and then people show up and they're surprised they're talking to an addiction doc, and that warm handoff from the pain doctor to the addiction doctor has been another challenge that's, kind of probably hurt the care our patients have received. So those are my selfish answers.
No, they're not selfish at all. I think they're just reflective of the healthcare system in general. Let's turn to Gary, just because I think this issue of how we work across specialties and handoffs and patients' understanding of when they're going between providers certainly would be something I think you might have a lot to say coming from the world of family medicine.
Yeah, thank you. Thanks a lot, Helen. And actually, Charlie, that's a great handoff, warm handoff that you just gave me there, because I try to make certain that my patients that are being referred to pain specialists know why they're going, because some of them want to go there to get stronger medications, and then they're surprised that, oh, well, they're not going to just give me my pills. So again, I try to make sure that they understand why they're getting there, but I realize that a lot of times they come back and they're frustrated because they didn't get what they wanted. And I do tell them from time to time that in medicine, the customer is not always right. The customer doesn't always get what they want. So, I'm really surprised that we've gotten this far into the conversation and we haven't heard the term, the fifth vital sign, which kind of got us into this social mess. And these guidelines have become somewhat of a legislative hammer or a law that we feel that we have to follow. So they're not guiding us as much as they're demanding that we do exactly what the legislative body has said, that this is a law. This is now the community standard. So that's kind of a negative of what we've been discussing here this afternoon. But, these positive is that the prescribing guidelines have provided practices with some degree of legal cover when the patients are demanding larger quantities of these narcotic medications or addictive medications, and, they want stronger meds. And it's helpful to be able to use the prescription drug monitoring portal information to have a mature conversation with the patients about drug-seeking behavior. One thing that used to just drive me a little up a tree and down the other side was having to do the drug talk with the patients over and over again. And so now I have some objective measures that we can use to say, well, look, we see that you've been getting medications from the emergency room, the urgent care, the doctor, whomever over here. And so they realize that we know more about what their activities are and what they're doing. This is an objective, visible evidence that can be an invaluable tool in any practice. And stop the flow of patients. But, one of the negative parts of it is that it stops the flow of patient care during the day to have to do these interventions, and it can be very time-consuming to, pull up the prescription drug monitoring portal and to have those discussions when you have 15 minutes with each patient to deal with what they came there besides just the pain medication, which often takes a lot of their time. But overall, it's decreased the drug-seeking behavior in my office and such. But again, as I mentioned, the real negative of this has been the fact that it increased the number of deaths from street drugs, because patients were driven out of our offices and into the street to find substitutes for these medications that they were now physically addicted to. And I had done some work with the Montgomery County jail population, and it ballooned during that time frame from 2010 to 2020 present, because of people using so many of these addictive medications. And it actually became the #1 drug rehab center in Montgomery County. And that was not by intent, but that's what's happening in our jail system. So that was the negative social fallout of it.
Yeah, thanks, Gary. That's a really important implication we haven't really talked much about in our work group yet. Tripp, I know you're going to want to say something about the lack of your PDMP, but anything else you would like to add about this question?
Yeah, I just have this surge of jealousy every time I hear PDMP because that makes life easier. I'm going to stick with the theme of being selfish and talk about our own practice and how these things have changed. Going back to in my early days of my career, it was kind of like the wild, wild west out there on one end of the rubber band, and we decided we were going to do something. And my dad is also a pharmacist. He's in addition to that a 25-year, now retired, drug diversion investigator for a multi-county task force. So that was our solution to helping solve the problem back then, pre-PDMP, pre-guidelines, is get involved and try to help from a law enforcement standpoint. Now let's take the rubber band to the other side. Now we decided, and these guidelines and opioids obviously have a lot to do with everything that's going on in pharmacy practice now, and have been for the last several years. But even stepping back to holistic patient care, we're focusing on social determinants of health now a lot. We've incorporated community health workers into our pharmacies, and not only into the pharmacy, but into the pharmacy workflow to help identify whole patient situations. And I'll tell you why. One of our first interventions with a patient was we had somebody that was on opioids. The prescriber was, let's see, first the third party stopped paying for it. Lady she's a bariatric patient, very, very large. She was on somewhat of a high dose. So we engaged as one of our first community health worker engagements, engaged this patient with a home visit and discovered that she had a broken leg. Her hospital bed was broken. She had been discharged from the hospital with some blood clots, and while she was there, they discovered she had a broken leg. When she got home, they set up her hospital bed. It broke. She was very depressed. Transit came to pick her up because she needed to go to physical therapy to get her on her feet, get her off her opioids, get her back rehabbing. But Transit refused her because of her weight. So what she turned to more opioids. So what we were getting from the prescriber, from the third party side was too many fills, too often, too high dose, etc. When we started digging in, we were like, this problem is so much greater than MMEs. So we're figuring out that, wow, we really have to engage patients holistically, which is what we've been doing, and that's positive. It's been so positive for our pharmacy practices. It's been positive for our communities. It's been great. Problem is, now what? Okay, so we've discovered all these things. Something I'm jealous about are all these resources I'm hearing about on the phone and the great work that my colleagues on this panel are doing. We don't know where you are. We have a hard time. We discover these things. Our community health workers are experts in resources that are available locally, and a lot of these things we just don't have. So, you get into what do we do when we discover these things and we really want to be change makers, but then also who pays for it? We're not getting paid for this. We're barely getting paid for the drug. Our reimbursement's terrible on prescription drug product right now. So who's actually invested in this? It's definitely an acute concern with our practice now, because we have engaged in social determinants of health and really discovering what's wrong with the patients holistically that we're dealing with. And what we're discovering is it's a lot more complicated than MMEs with opioids.
Yeah, I think all of you have highlighted the complexities of these guidelines and how they're being interpreted, and certainly the negative effects on illicit drug use, drug seeking all of that is something really of concern. Tripp and several others sort of mentioned this issue of payment, and that I think takes us nicely into our next question, which is kind of going at a different level here, which is we'd love your reflections on any intended or unintended consequences you've experienced from the policies, regulations, and payer requirements that they have based on these opioid prescribing guidelines. And then give us some recommendations for how to address them. And I'll mention that we specifically put this in here because I think there were some concerns that even if the guidelines at times were, could be interpreted appropriately, as that New England Journal paper tried to highlight, oftentimes there are folks on the ground who are actually implementing the policies through regulations and payment who may in fact be using them differently and may have unintended consequences. So with that, let's hear your thoughts about intended, unintended consequences on regs and payment, and then specifically how you might address them. So with that, let's turn to Matt first this time.
Thanks, Helen. And in fact, Tripp's comments just now really lead nicely into this. For me, I think of a situation that's getting better, but is still not optimal. For instance, payers will easily cover a range of analgesic and opioid therapies for chronic opioid treatments. But initially, and still we see there are restrictions and sometimes severe restrictions, at least in the past, on covering buprenorphine. And that the authorizations for buprenorphine would take a long time. I also think that state Medicaid should not require counseling or psychotherapies when patients receive buprenorphine, because we know that some patients cannot or will not engage in psychotherapies. And we know that some treatment, for instance, buprenorphine alone, is better than no treatment at all. We know that patients are at risk for opioid-related overdose deaths when their pain is untreated and when their opioid use disorder is untreated. So I would rather the patient be on buprenorphine alone than on nothing at all. So my recommended solution here is to hold payers accountable, first of all, for following the Affordable Care Act and the Mental Health Parity and Addiction Equity Act. And I would also recommend a solution here that state Medicaid should not require counseling and psychotherapies with treatments. The other thing I'll note, consequence has been that buprenorphine is really underutilized as a safer alternative to full opioid agonists in the management of both acute and chronic pain. So my recommended solutions here include, number one, that sublingual and buccal buprenorphine should receive FDA approval for pain management, and that number two, the federal requirement for 8 or 24 hours of provider education to receive a buprenorphine waiver should be lifted in favor of some other mechanism that provides appropriate education for clinicians to safely prescribe any opioid analgesic or controlled substance.
Those are some big, important policy levers. Gary, I'll turn to you next.
Sure thing. Thanks, Helen. Until the prescription drug monitoring portal was actually integrated into my electronic health record, it was a hassle to have to sign out of my patient's medical record to get into the portal to check their history and such. Fortunately, now it's been remedied for my practice, but not all practices. And sometimes, like when we were talking about, sorry to bring this up, Tripp, but in Missouri, when I visited there, that was one of the complaints that they had. That why don't we have that when all the states surrounding them have the prescription drug monitoring? And so, if you've kind of seen one system, you've seen one system, because there's so much difference from state to state. And I think one of the biggest things that I hear from our members, our colleagues and such, is just the change fatigue. Just the fact that it seems like once you think you've gotten your head wrapped around what the guidelines are, what the community standards are, and the expectations, then something else changes from a federal level, from a state level, from a county level, from a network level and such. And it's really hard to really be able to say, I can follow these guidelines. They're very complicated and they're very time consuming, and some physicians simply just give up and just dismiss the patients who are in desperate need of care. They just dismiss them from the practice, and they're more concerned, and I'm talking about the clinicians, more concerned about the possibility of losing their medical license because they're not following these guidelines precisely. With this kind of shifting network of opiate prescribing guidelines. And pain management referrals are not always available in a timely manner. And so I have these patients where I referred them for pain management because of no other alternatives are available to them in my practice, and they can't get in. Or, the referral kind of times itself out. And as I said earlier, some of those patients go to pain management care often return because they don't want procedures, and that's what's being offered to them. And so, they say they want something other than a procedure, and there's nothing there to offer. And then, as was mentioned earlier about the payers not paying for alternative care, pain management relief, like cognitive psychiatric care or MAT or massage or rehabilitation, physical therapy and such. And so they're left kind of stuck there, not able to get what they need to relieve their pain. And so that is the conundrum that we face.
Yeah, really important points there, Gary. Tripp, I'll turn to you next.
I want to echo what Gary just said about the fear of losing a license, because we've experienced that. Pharmacies experience that concern, but we've heard it a lot from our partner providers in our communities. There's often a lot of confusion around what can be done and what can't be done, and difference between rigid guidelines and non-rigid guidelines, which is kind of where we're walking. Okay, for this question, I am really looking at this as unintended consequences, and I just want to put a stamp what I think is one of the drivers of unintended consequences, and it's I think driving a lot of our overarching healthcare burden right now in our country, and it is the 12-month benefit cycle. Because you see it on the medical side, but we also really, really see it on the prescription side. If it's attributed to the payer during their 12-month benefit cycle, that's not good. They would rather it not be on their record for that 12-month benefit cycle, or they would rather kick that to somebody else. We see it a lot of times in prescriptions, and we've seen it definitely with opioid prescriptions. So if I'm a payer, if I'm a health plan that's got a pharmacy benefit manager, that health plan PBM combo, they would rather not have a lot of high MMEs on their roster, because there are metrics associated with that, and these guidelines are being implemented, which is why I think we're seeing a lot of unintended consequences. Because what we do is we see a lot of let's just defer to more rigid versus less rigid, because it's safer for us from a regulatory standpoint. And then you get into, I like the term legacy patients, because we see a lot of those. What do you do with a legacy patient on a new 12-month benefit, on a new Part D plan? Well, they're a new patient to that Part D plan. They may have been on opioids for 15 years. So what we're seeing is this patient is really the one that every January or every new benefit cycle, they're seeing things like drug utilization reviews, prioritizations needed, new diagnosis codes submitted, quantity limits, documentation required, maybe formulary edits, and it's every 12 months. It's very, very disruptive, and it's hard to put a strategic plan together with an individual patient when you're looking at 12-month benefit cycle change. So we've seen a lot of unintended consequences specifically related to coverage during the 12-month benefit cycle, and I don't know that I've got a really good answer for it, other than if if patients could be treated, we as even taxpayers or just human beings, treated as investments and not just 12-month members on a benefit, I think that we can invest money in long-term strategic plans that right now is not conducive to the current healthcare market. That's a lot bigger than opioids, but I think it's a driving piece of what we're seeing.
Absolutely. No, that makes perfect sense. Charlie, I'll turn to you.
Okay, yeah, this is a great conversation. I want to talk about upstream in consequences and downstream consequences. So upstream, I'm on a committee for the state of Minnesota trying to develop regulations of opioid prescribing, and it's not that hard to have a group of people get together and say what's best practice, but then to create regulations based on that. There's two things I want to call out. One is I challenge our group. I'm not the only one, but I challenge our group to say, look at our regulations. Look at this proposed regulation. Does this disincentivize care for people who need opioids? And if so, how are we going to deal with the fact that we're disincentivizing prescribing opioids? People who need opioids won't get them because we are actively disincentivized. That's on us. And it's quite hard to implement a regulation to assure best practices without simultaneously disincentivizing opioid prescribing to those who ought to be prescribed opioids. It's quite hard to do that. So that's number one. Regulations have disincentivized opioid care. Two, even if we nailed it perfectly, how do we communicate the subtlety of our regulations? And the communication challenge is huge because docs are busy, providers are busy, and we got to communicate some nuanced regulation to them. They don't have time for that. All they just don't prescribe opioids. So even if we do a great job, they're hearing the wrong message because communication is such a challenge. And this hits our most vulnerable patients the hardest. I mean, the highest dose benzo-opioid co-prescribed patient with a mental health diagnosis and maybe substance use disorder diagnosis, that's the most vulnerable person. And they're going to be hit by these unintended consequences disproportionately. And so it's very, very hard to regulate without creating these unintended consequences. So that's the upstream. The downstream is already mentioned. Docs are checking out. They're just saying this is all too complex. There's too many regulations. I don't have time for this. And they don't want me to prescribe? Okay, I won't prescribe. And then the couple things happen there. One is in our institution, we have a number of providers who are retiring. And when they retire, their cohort of patients being prescribed opioids, who takes those over? We don't have any providers in our institution looking to take over opioid prescriptions. And it's hard for us to tell them, you must take over those opioid prescriptions. And that's an unintended consequence of all this, is nobody wants to touch it anymore. The second thing related to that is what we're seeing in Minnesota, and I suspect across the nation, is a consolidation of opioid prescribing into sort of high-volume pain centers. So all the primary care providers are sort of saying, I can't handle. Primary care providers are busy, and this is becoming more and more complex. And so with the increasing complexity of opioids, they're just outsourcing to pain clinics. And that could be a good thing or a bad thing, but we're seeing a consolidation of opioid prescribing in fewer and fewer high-volume pain clinics in our community. So again, that could be a good or bad thing, but it's happening. Yeah. And then the final thing that I'll say, which is a troubling downstream effect of these regulations, is the very fraught interactions between doctors and providers and clinicians, advanced practice providers, and their patients. I mean, we have some instances where security is called because the patient is so angry and the doc is so on edge that it escalates to this event that should never happen, where we're talking about a prescription and suddenly security is involved. And that shouldn't happen. That doesn't have to happen, but it's happening. And it's very worrisome that these regulations have trickled down to interrupting patient-provider fracturing care like that. So I think those are my worries.
Wow, lots of worries for the first four of you for sure. Mark, how about you?
So I'm going to maybe take a different tack because I think people have dealt pretty well with the day-to-day and week-to-week clinical issues. I hear an awful lot of use of the pendulum metaphor these days. I heard a rubber band metaphor about opioid prescribing being more liberal, less liberal, more popular, less popular, which is a little too fatalistic for me. I think that we are learning more about these medications in the process, and that the swing of the pendulum is not simply back to where we were. Let me say, we're still far beyond the level of opioid prescribing that was happening even as soon as 1999. We're at least at 4 times the level of opioid prescribing that was occurring in 1999. So the pendulum, even though it feels very restrictive, it has not returned to where it was in 99. 2, I think one good thing about the opioid crisis, as they say, never miss a chance to use a crisis as an opportunity. And it has certainly allowed us in the pain academic community to ask broader and more searching questions about pain and opioids than would have ever been possible had we not had this whole thing blow up in our face. For example, I think that we were operating with a very superficial sense of what opioids do, as if they were pain-specific medications, or as is used as a synonym in popular press, painkillers. And that's in fact a way that patients will talk to me. I mean, they say, don't give me any of those mind-altering drugs, meaning anticonvulsants, antidepressants, et cetera. Give me, pain medicine to take my pain away, which assumes that opioids are solely directed at pain, which is not consistent with, 40 years of endogenous opioid science. The fact is that opioids are one of the most potent and universal stress modulators in the brain. They serve really important functions for humans, particularly social bonding functions, which appear to be disrupted by long-term opioid therapy. There are harms of opioid treatment that are not just overdose and addiction. Many of the neuroadaptations that occur with long-term exposure to opioids do not require the development of addiction. Hypogonadism, hyperalgesia. A lot of these social and emotional functional deficits don't require addiction. So we have been developing an idea of complex persistent opioid dependence as another type of thing. So I think we're learning things. I mean, there's a lot of pain and a lot of problems going on in the society about this. I think patients are suffering. There's difficult interactions between providers and patients, as the other panelists have been describing. But we're not simply going back to where we were before. A, we haven't gotten there. B, we're learning more on the way.
Absolutely. Well, you've raised collectively a lot of really important issues, most of them, I would argue, pretty negative, around the rubber band, the pendulum, where are we swinging, where is this happening, what's the effect on potentially licensing issues, the effect on illicit drug use again. I think the issue of people going to pain clinics is an interesting one as well. Certainly my local experience would suggest even if it's appropriate, it's really difficult to get in. So kind of offering people solutions that don't sort of lead anywhere certainly is a real challenge. And I think the issue that was raised around there really being a communication challenge, people even understand what the implications of the policies and regulations is very, very important. So we're going to turn to the next question is, what would you change in the healthcare system? If you had a magic wand, what one thing would you change to improve care for people with chronic pain? I'll go ahead and start with you, Trip, this time.
I like this one. I'm with you. I feel like this has been somewhat, and a lot of my comments have been negative because unintended consequences seem to be where we are. I am typically a glass is half full kind of person, and I'm notoriously optimistic, so I like this question a lot better. And sometimes if you had a magical wand, it actually turns into a magical wand and you can do things. So I'm a independent community pharmacist. I'm also a member of an accountable pharmacy organization that's clinically integrated with over 2,500 members, and we're all independent community pharmacies. So we're actually working on this. Our goal is, and what we think needs to happen, is that the industry needs to really look, and I'm speaking specifically to pharmacists and pharmacies that in the past maybe haven't looked at it this way, but we're essentially the last line of defense in opioid use. And so we've got really a corresponding duty of care along with the prescribing physician to do the best we can. And so what we're working on and what we think needs to be done is really a dual approach. One is for new onset opioid prescription patients, and then another for those legacy type existing patients. And ensure that when that patient is in the pharmacy, that the pharmacist can deliver a very standardized service to that patient at the time of dispensing or in preparation for dispensing, using a service that's tailored to that patient, although standardized, which you can actually do both. And it consists of education on opioids, alternatives, realistic expectations. I mean, that is the gap in care that we've noticed locally is nobody says, hey, you might hurt after surgery a little bit. This could help with your pain, but you're probably not going to be pain-free, and at minimum, there's going to be some discomfort. That conversation needs to be had, and I don't feel like it's something that is spoken all the time. I know we don't do it enough. Also need to talk about overdose potential, family members, children that could have access to opioids, naloxone co-prescribing, and then talk about things like pharmacogenomic testing. We hadn't talked about that. Medications, drugs are metabolized differently in different people's bodies. Maybe there's a nuance in a person's anatomy that makes them more or less likely to have success with an opioid. So as these things are done, I think this service needs to be done in collaboration with the patient, the prescriber, with every new initiated prescription. I don't see why it can't be done. My organization, this accountable pharmacy organization, is working to standardize that as we speak. Then you get into the secondary is that's all fine and good, but what about these patients that have been on opioids for a long time? The conversation's a little bit different. It's more like care planning. We need to be sitting down with these patients regularly and talking about realistic expectations, do some risk screening additionally to maybe what's been done previously, have this naloxone conversation and reduction in use conversations, coping strategies, refer to counseling. There are a lot of things that we can do because we do have access to these patients. There's a report that came out of our organization in North Carolina that showed that patients that they were really high risk chronic condition, a lot of them opioid patients, had seen their primary care provider 3.5 times a year, and these were in the Medicaid program in North Carolina, but they had touch points with their pharmacies 35 times a year. So that's 10 times more touch points a year for patients. We need to utilize that as pharmacists, and I think the community pharmacies are the place for that. Problem is, who's paying for it? I think there's huge value here. I know a lot of pharmacies that are willing to do this. And we've got an organization that's moving forward right now to create the infrastructure for these services. But payers have to recognize that it's more than just not covering the adjudicated prescription claim that they're responsible for during that 12-month benefit cycle, that actually this is a long-term care plan that we need to work on with this patient, and we can really make a difference from a community pharmacy standpoint when we've got the ability to work longitudinally with patients and with the whole care team, with their providers and everybody involved. That is my magical wand moment.
Great. Thanks so much, Trip. Charlie, how about you?
Yeah, I have a quick one. So I'm going to take the liberty of saying that I really want to say hear to the comment about the pendulum being a misleading metaphor. And the pendulum, thinking that our attitudes about opioids are just on a pendulum that swings back and forth, is in essence nihilism. And there's nothing that governs our opioid prescribing decisions other than this pendulum which swings back and forth. And I don't believe that. And I do believe we're getting better. We're getting more information. We're taking care of our patients better. And these guidelines do serve a meaningful purpose. But boy, are there growing pains. And so I overall don't believe we're on this nihilistic, vacillating, oscillating care of opioids, and we're just going to be back to where we were in no time. I believe we were making good changes, and it's just growing pains. I mean, we've got some serious growing pains, and we got to work things out, but we're making progress. I believe that. My magic wand is simple: improve reimbursement for treating patients in pain. And the complexity level, it has always been more complex than we thought it was. And now we are acknowledging the complexity level of treating patients in pain, especially with opioids. And our reimbursement for doing so should match the level of complexity. And I mentioned before, there's a lot of things disincentivizing care of these highly complex patients. I think we got to start incentivizing care of these highly complex patients, and that means money. And let's make it a sought-after job again. And so I guess that's my pay for good people to do good work, and you'll get good people to do good work, and that's my hope.
Sounds great, Charlie. Okay, Mark, how about you?
So I think I'm going to get on Charlie's bandwagon in maybe a simple way and just say that we have been a lot better at restricting access to opioids than we have been at opening up access to non-opioid care. And availability of qualified practitioners, coverage for services from physical therapy to psychotherapy to non-opioid medications is still far behind the restrictions on opioid therapy, probably because restricting access to care is cheaper than providing access to care. But, also the other commentators have made a lot of points about short-sighted 12-month kind of cost accounting, and the population costs of this opioid experiment have been catastrophic. So I think that we need to get ideas that have been largely restricted to like academic and tertiary care medical centers. A lot of pain psychology is stuck in those places, and it's not really gotten out in any meaningful way to primary care offices. New goals, new regulations. People like to talk about what a bad idea the fifth vital sign was, which I agree. I also think the 0 to 10 pain scale is a bad idea and should be banished from chronic pain care. Maybe in post-op care it's okay, but chronic pain care, it's bad on many levels. So I think we need a set of new standards as well as access to a different set of services if we're going to complement the switch away from opioids.
Absolutely. All right. Let's go to Gary, please.
Great. Thanks a lot, Helen. And I want to take this opportunity to thank our panelists for their comments. It's been enlightening for me, hopefully also for those that are listening. As far as this question, I love the question about the magic wand, but this isn't magic. It really does take time, training, patience, and trust of those individuals that we serve and that come to us for care. I guess if I had a functioning magic wand, I would use it to somehow rid the human body of pain once the damage that caused those pain receptors to fire has been eradicated. And I use my magic wand to increase public awareness about the solution to the opioid crisis, and that it's not simply just stopping clinicians and surgeons from prescribing opioids, because pain is a necessary signal. That's basically saying that there's some sort of malfunction within the body's ecosystem. However, addiction itself is not a necessity to pain management. And the opioid crisis can't be halted by just simply mandating that medical prescribers take a 20 to 30-hour online course or attend the seminar. In fact, we have so many groups of individuals that have been given legislative authority to prescribe addictive medications, and not just opioids, but all these various combinations cause addiction. And without the appropriate knowledge given to those individuals that are given the privilege to prescribe medication, it causes, it can lead to addiction. So it's not just a primary care problem, because anybody that can prescribe these medications that are addictive can contribute to this problem. Patients didn't get into this predicament because they just simply woke up one day and said, hey, I want to be a drug addict. I've never had a patient that came into my office and said that. Chronic pain management is multifaceted, and it's about increasing awareness of how we can treat pain appropriately and recognize that many of our patients have pre-existing addictive potentials or personalities, and our society cannot just legislate this away. As I mentioned several times in Montgomery County, the new laws and the guidelines are great, but they're not magic. They're not the magic we're looking for. And basically, we saw that it just simply drove the patients and the problem out of our medical facilities and into the streets where the death toll increased. So awareness is the first step towards cure. Awareness is, I guess, the magic we're looking for. And so I really appreciate this opportunity to have this conversation and increase awareness of those individuals that are listening and those individuals that will step us, not slingshot us back to where we were before the beginning of this century, but slingshot us forward with awareness to a better society where addiction is something that is of historical significance and not what we live with day to day.
Yeah, thanks so much, Gary. I will mention that the Opioid Collaborative has really tried to take on and see what we can do around the issues of stigma and the issues of awareness here for both clinicians and providers, or for clinicians and patients and their families, is really important. All right, Matt, I think you get the last wand.
Well, thanks, Helen. I definitely at this point want to join Tripp and Charlie in saying despite previous answers, I am also a glass half full person, and I really like the magic wand question. It really helps me and hopefully all of us imagine what's possible and what's achievable. So with my magic wand, I would hope that given the high rates of chronic pain in the U.S. population, that a magic wand could somehow provide more multidisciplinary and more multimodal clinical entities to treat chronic pain, and that these entities could be, appropriately staffed and funded medical homes and existing primary care clinics. I also think that a magic wand could produce more visible public education on the various benefits and risks associated with chronic opioid therapy. And just a nod to Dr. Sullivan for mentioning, the risks of chronic opioid therapy go well beyond behavioral manifestations too, and really involve a lot of different body systems and social systems as well. And then finally, I'm also going to say this about the magic wand. It may seem far-fetched, but I don't think it is. I think a magic wand could provide focus on chronic pain prevention, or at least focus on reducing the factors that amplify the broader suffering that's associated with chronic pain. So a magic wand perhaps could create significant governmental support for meaningful human engagement in rewarding and appropriately compensated work, including appropriate work training and education and work safety measures. A magic wand could include better vacation pay and paid leave, and better pay overall, all of which are stress reducers, because we know that when stress is reduced, pain is reduced. And a magic wand could also create government policies that support education and small businesses, which in turn could support thriving communities and perhaps potentiate a decrease in what have been termed deaths of despair. And maybe a magic wand could provide timely and affordable health benefits that quickly and appropriately address acute injuries, recovery from acute injuries, and ongoing healthcare maintenance, which may prevent the development of chronic pain.
Those are really a remarkable set of answers. Thanks to all of you for weighing in. I actually have the New Yorker cartoon in my office framed from my prior bosses, John Eisenberg, of the glass half full. So I'm with all of you, and I think you've raised a lot of really important points, and I think it also points out the wisdom of having a collaborative that includes both the public and the private sector, as well as work groups that cover things from treatment and guidelines in our group, but then also issues around prevention, stigma, awareness, treatment. So I think you've laid out, I think, a very logical course for what we need to do to attack this issue collaboratively. None of us can do it on our own, which is why we wanted to have this this group of different clinicians talked with us today. So I just want to thank everybody. It was really a remarkable discussion. I've been getting some comments from folks about how much they've appreciated your honesty, your willingness to really talk through what is important. And I want to personally thank each of you for making this just a delightful webinar to moderate today. And just as a reminder, we will have the opportunity for listeners to participate in this session. We won't have time on the webinar itself today to open up for discussion, but we will allow you to provide written responses on the discussion questions we've covered today. Those will be available on the link that's shown on your screen here. We will gather all those comments and pull them together and capture them in the Action Collaborative's our journey map that we're trying to put together. So hearing the experiences so far of the lived experience of patients, and today really the lived experience of those who care for them, has been invaluable. We want to thank you for being engaged with us on this really important topic. And again, thanks to our presenters today. And I believe, Aisha, do you want to wrap us up and take us to the next steps?
Yes, absolutely. Thank you so much. I just wanted to conclude the webinar by extending a special thank you to all of our speakers and to all of the attendees as well for listening in and for participating. Should you have any questions or comments about today's session, you can always reach out to the email address that is provided, which is opioidcollaborative@nas.edu. Well, thank you again. And again, this webinar is recorded, and so we will be posting it on our website in case you would like to access it in the future. Thanks again, everyone.
Great. Thanks again, everybody.
Thank you.